Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 322 of our pharmacotherapy series, which majors in shock. The first question refers to patient DEB in part 221 of this pharmacotherapy series. Given DEB's history of cardiovascular disease, what factors should you consider before initiating an inotropic or alternative vasopressor agent? Outline an overall approach to maintaining adequate hemodynamic status. DEB has a history of coronary artery disease and is susceptible to myocardial ischemia. Therefore, a careful balance must be achieved between myocardial oxygenation and coronary perfusion pressure. Further attempts to optimize MAP and cardiac index with norepinephrine alone could increase myocardial oxygenation and precipitate ischemia. Evidence suggests that the goal of therapy in treating patients with septic shock, or any form of shock for that matter, is not to simply normalize BP but to optimize oxygen delivery and oxygenation. Once anemia and hypoxia have been corrected, cardiac output becomes the remaining parameter that can be adjusted to increase oxygen supply, but raising arterial BP and cardiac output with inotropic agents or vasopressors before restoring adequate blood volume can actually worsen tissue perfusion. Therefore, the patient's current hemodynamic status and the individual properties of those agents that will most effectively maintain or increase the MAP and cardiac output should be considered while selecting an inotropic agent. In many instances, because of individual variability and response, more than one inotropic agent or addition of a vasopressor is required to achieve these endpoints. These interventions must be made with strict monitoring of the patient's response to the interventions to prevent any adverse consequences, especially in those patients who are predisposed to an adverse event, such as DEB. It is important to realize that the response to exogenous catecholamines in patients with septic shock is highly variable, and a successful regimen in one patient may be unsuccessful in another. In addition, septic patients often require infusion rates in the moderate to high range. Therefore, the goal is to use one or more agents at the dosages necessary to achieve the desired endpoints without unduly compromising the patient's status. The use of catecholamines, however, is only a stabilizing measure. Strict attention to all other physiologic parameters, as well as nutritional support, antibiotic modification, respiratory support, and ongoing surgical intervention, cannot be overemphasized. We will now look at other therapies. Therapies directed against the initiators and mediators of sepsis are currently the focus of intense investigation. Numerous exogenous and endogenous substances are involved in the pathogenesis of sepsis within the cytokine and coagulation cascades. Strategies under development include antioxidants and free radical scavengers, anti-endotoxin therapy, and inhibition of leukocytes, secondary mediators i.e., TNF-alpha, IL-1, and the cytokine pathway, coagulation and arachidonic acid metabolites, complement, and nitric oxide. The lack of development of successful new therapies over the past 2 decades is probably because of multiple factors, such as poor clinical trial design, oversimplification of the pathologic process in animal models, and suboptimal patient selection criteria. Although several experimental therapies hold promise for the future, controlled human trials are still lacking. The next question reads, what is the rationale for the use of glucocorticoids in the treatment of septic shock, and is there evidence to support their use for this indication in DEB? The use of corticosteroids in sepsis and septic shock has been a controversial topic for many years. Corticosteroids were originally proposed as a treatment option because of their anti-inflammatory properties with the hope of attenuating the body's response to infection. It has been shown that critically ill patients exhibit impaired cortisol secretion because of a relative adrenocortical insufficiency and a glucocorticoid peripheral resistance syndrome that can also be affected by multiple medications. The Consensus Task Force from the American College of Critical Care Medicine has defined this dysfunction of the hypothalamic pituitary adrenal axis as critical illness-related corticosteroid insufficiency. Diagnosis of this condition is intensely debated. Some clinicians recommend a random cortisol level that is below a certain threshold during physiologic stress, i.e., shock, to diagnose adrenal insufficiency. However, this has only been shown to be useful in diagnosing absolute adrenal insufficiency. The traditional assessment method has been the adrenal corticotropin hormone, abbreviated as ACTH, stimulation test with administration of either 1 microgram or 250 micrograms of concentropin. Though, the adrenal corticotropin hormone tests only evaluates the adrenal function, not the entire hypothalamic pituitary adrenal axis, and lacks sensitivity and specificity in critical illness. Random cortisol levels may be useful for evaluating absolute adrenal insufficiency but have not demonstrated a benefit in septic shock patients. The Surviving Sepsis campaign does not recommend the adrenal corticotropin hormone stimulation test or random cortisol levels to identify patients who should receive glucocorticoids. Clinical trials investigating the use of steroids in septic shock have been performed with varying results. The trial by Anane and colleagues showed a shortened time to shock reversal and mortality benefit with the use of low doses of hydrocortisone and fludrocortisone in patients with severe septic shock, who exhibited a relative adrenocortical insufficiency, serum cortisol increase less than or equal to 9 micrograms per deciliter in response to adrenal corticotropin hormone stimulation. The CORT-ICUS trial showed a faster resolution of shock for those patients on hydrocortisone as evidenced by faster time to weaning from vasopressors. However, those patients also had a higher incidence of superinfection and new episodes of sepsis or septic shock. There was no mortality benefit seen with the use of corticosteroids. The CORT-ICUS trial included patients with septic shock, whereas the study by Anane and colleagues only enrolled patients with severe septic shock unresponsive to vasopressor therapy. A recent retrospective study in patients with septic shock noted a neutral effect with corticosteroids, but a subgroup analysis revealed a 30-day mortality benefit in the patients with the highest severity of illness. Additionally, refractory patients who have progressed to vasopressin therapy may have an even greater benefit. In a post-hoc analysis of the VAST trial, treatment with corticosteroids and vasopressin was associated with decreased organ dysfunction and mortality compared with corticosteroids and norepinephrine. The results of these studies demonstrate that corticosteroid therapy may not have a role in the general population of patients with septic shock. However, it may be beneficial for those patients unresponsive to vasopressors who are treated early. The optimal dose, duration, and method of administration are still unknown. The Surviving Sepsis campaign recommends hydrocortisone 200 mg per day. Continuous infusion of hydrocortisone may avoid significant fluctuations in glucose and sodium. Because DEB is refractory to increasing doses of norepinephrine and is in severe sepsis, it was decided to start hydrocortisone 50 mg IV every 6 hours. The next question reads, should DEB be started on a statin? Are there any differences in outcomes for patients taking statin therapy prior to developing sepsis? Aside from their well-described lipid-lowering effects, statins appear to have immunomodulatory and anti-inflammatory effects. Statin therapy lowers C-reactive protein levels, inhibits endothelial cell dysfunction, causes upregulation of endothelial nitric oxide synthase, and blocks immune cell receptors. A recent meta-analysis of 7 randomized, controlled trials comprising 1,720 septic patients did not show a decrease in mortality outcomes compared to placebo, regardless of the type of statin, dose, or observed mortality rates. Statins are often discontinued in septic patients because of concern for adverse effects and further organ dysfunction. Presently, it is not clear whether statins should always be continued in septic patients. Recent studies in patients who were taking statin therapy prior to sepsis have not shown any difference in outcomes or rebound inflammation when discontinuing therapy. More prospective, randomized trials are needed to further define the role of statins in sepsis. The next question reads, DEB experiences sudden appearance of bright red blood per rectum and through her nasogastric tube, thus, a coagulation screen was ordered. Until this time, all coagulation parameters had been within normal limits. Now the results show the following. Platelets of 43,000 per microliter. Prothrombin time of 24 seconds. Activated PTT of 76 seconds. Thrombin time of 48 seconds. The normal range is 16 to 27 seconds. Fibrinogen of 60 mg per deciliter. Fibrin degradation products of 580 nanograms per milliliter. The normal value is less than 250 nanograms per milliliter. The diagnosis of disseminated intravascular coagulation, abbreviated as DIC, is made. How does the pathophysiology of disseminated intravascular coagulation explain these hematologic abnormalities? Thrombosis in response to endothelial damage or the presence of an altered surface in contact with blood components is a localized phenomenon. Thrombus formation occurs at the site of injury or abnormality, where procoagulant and anticoagulant mechanisms, as well as fibrinolytic and antifibrinolytic mechanisms, are regulated. The term localized extravascular coagulation describes the site-specific nature of venous and arterial thrombosis. In contrast, disseminated intravascular coagulation is a diffuse response secondary to an underlying disorder that causes systemic activation of the coagulation system. Circulating thrombin converts fibrinogen to fibrin, resulting in fibrin deposition within the microcirculation. Clinical manifestations of microvascular thrombosis are the result of tissue ischemia resulting from thrombotic occlusion of small and mid-sized vessels. The presence of systemic circulating thrombin causes simultaneous systemic activation of the fibrinolytic system, resulting in circulating plasmin within the systemic circulation. Plasmin causes systemic lysis of fibrin to fibrin degradation products and results in hemorrhagic complications. Bleeding manifestations of disseminated intravascular coagulation occur not only as a result of systemic fibrinolysis but also secondary to thrombocytopenia, clotting factor deficiency, and platelet dysfunction. Circulating thrombin promotes platelet aggregation, resulting in thrombocytopenia as platelet aggregates deposit in the microcirculation. Circulating plasmin degrades clotting factors as well as fibrin, and the presence of fibrinogen degradation products from fibrinolysis inhibits platelet function. Normal mechanisms of platelet and clotting factor synthesis are unable to compensate for this consumption. In essence, the patient shows paradoxical bleeding secondary to overactivation and eventual consumption of available clotting factors and platelets. The next question reads, what events may have precipitated the development of disseminated intravascular coagulation in DEB? Disseminated intravascular coagulation is a pathologic syndrome triggered by disease states or conditions that activate coagulation systemically rather than locally. The presence of thrombin within the systemic circulation can be triggered by systemic endothelial damage, e.g., bacterial endotoxin, systemic contact activation of the clotting cascade, e.g., cardiopulmonary bypass, or the release of procoagulants into the systemic circulation, e.g., malignancy. Disseminated intravascular coagulation complicates approximately 35% of severe sepsis cases. Although sepsis is the most likely stimulus for disseminated intravascular coagulation in DEB, both hypoxia and acidosis associated with respiratory compromise may also have contributed. Importantly, the development of disseminated intravascular coagulation in septic patients has been shown to be an independent predictor of mortality. The next question reads, what subjective and objective evidence in DEB is consistent with the diagnosis of acute disseminated intravascular coagulation? We will now look at laboratory findings. Many coagulation laboratory abnormalities occur in disseminated intravascular coagulation. The ratio of PT to international normalized ratio, the activated PTT, and the thrombin time are increased because clotting factors, as well as antithrombin and proteins C and S, are consumed more quickly than they can be replenished by hepatic synthesis. Platelet count is diminished secondary to thrombin-mediated platelet aggregation. Fibrinogen is reduced as a result of plasmin-mediated fibrinolysis, with an elevation in fibrinogen degradation products including D-dimer, indicative of a fibrinolytic state. A peripheral smear will often show thrombocytopenia and red blood cells fragmented by exposure to microcirculatory fibrin, that is schistocytes. The International Society of Thrombosis and Hemostasis overt disseminated intravascular coagulation scoring system is used in the diagnosis of disseminated intravascular coagulation. The sensitivity and specificity of the disseminated intravascular coagulation score is 93% and 98%, respectively. There is a strong correlation between increasing disseminated intravascular coagulation score and 28-day mortality. We will now look at hemorrhagic manifestations. As illustrated by DEB, hemorrhagic manifestations are the predominant clinical finding in disseminated intravascular coagulation. Bleeding can occur at sites of injury, including surgical incisions, venipuncture sites, nasogastric tubes, or gastric ulcers. However, spontaneous bleeding also occurs from intact sites or organ systems. Spontaneous ecchymosis, petechiae, epistaxis, hemoptysis, hematuria, and GI bleeding are commonly encountered. Intracranial, intraperitoneal, and pericardial bleeding may also occur. critically ill patients with platelet counts less than 50,000 per microliter have a fourfold to fivefold higher risk of bleeding, but major bleeding occurs in a minority of patients. Next we will discuss thrombotic manifestations. Thrombotic manifestations of disseminated intravascular coagulation result in the obstruction of blood flow to multiple organ systems. The resultant ischemic damage to end organs, including the skin, kidneys, brain, lungs, liver, eyes, and GI tract, can result in multi-system failure. Despite the severity of hemorrhagic complications, microvascular thrombosis represents a significant cause of morbidity and mortality in patients with acute disseminated intravascular coagulation. The next question reads, in the course of several hours, DEB has exhibited more severe GI bleeding. Her hematocrit has fallen from 43% to 35%. What treatment course should be pursued? Should heparin therapy be given? The most important element of treatment in patients with DIC is alleviation of the underlying cause to eliminate the stimulus for continued thrombosis and hemorrhage. For DEB, this involves appropriate source control, antibiotic therapy, and supportive measures to correct or prevent the hemodynamic, respiratory, and metabolic manifestations of shock. Fluid replacement, maintenance of BP and cardiac output, and adequate oxygenation are essential components of the treatment of patients with disseminated intravascular coagulation. The selection of other therapies aimed at correcting the hemorrhagic or thrombotic manifestations of disseminated intravascular coagulation are controversial and to some extent depend on whether hemorrhagic manifestations or thrombotic complications predominate in the clinical presentation. Initial treatment in patients with hemorrhage involves replacement of clotting components that have been consumed in disseminated intravascular coagulation, guided by coagulation laboratory data. Transfusion of platelets, fresh frozen plasma containing all clotting factors, cryoprecipitate containing factor VIII and fibrinogen, or prothrombin complex concentrate containing factors 2, 9 and 10 and factor 7 for 4-factor products may be necessary, with close monitoring of platelet count and fibrinogen level. Several approaches to restoring the inherent anticoagulant pathways that are disrupted in disseminated intravascular coagulation have been attempted. Transfusion of antithrombin concentrates may improve survival in disseminated intravascular coagulation associated with sepsis. Recombinant human thrombomodulin is a promising new adjuvant therapy that targets the protein C pathway in the pathogenesis of disseminated intravascular coagulation. Recombinant thrombomodulin was associated with a higher degree of resolution of disseminated intravascular coagulation compared with heparin in a randomized clinical trial, but it is not yet commercially available and additional clinical trials are being conducted to confirm its potential role. Anticoagulation with heparin in patients with disseminated intravascular coagulation is controversial. In theory, because the initial pathologic event in disseminated intravascular coagulation is activation of the clotting system with formation of intravascular thrombin, the antithrombin activity of heparin should prevent further fibrin deposition and subsequent activation of fibrinolysis. However, randomized trials have not been conducted to confirm this potential benefit, and the role of heparin remains controversial. The Scientific and Standardization Committee on Disseminated Intravascular Coagulation of the International Society on Thrombosis and Hemostasis recommends considering therapeutic doses of low molecular weight heparin in disseminated intravascular coagulation cases with predominant thrombosis. The committee also recommends venous thromboembolism prophylaxis with low molecular weight or unfractionated heparin in critically ill, non-bleeding patients with disseminated intravascular coagulation. Finally, the use of the antifibrinolytic agents such as tranexamic acid and aminocaproic acid to control bleeding is relatively contraindicated. These agents may worsen the thrombotic complications of disseminated intravascular coagulation, particularly if heparin is not used concurrently. However, antifibrinolytic therapy or recombinant activated factor VII marketed as Novo-7 may be used in patients with life-threatening bleeding, who fail to respond to replacement of clotting components or to heparinization. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 323.